Good afternoon, everybody. Today we are here to talk about breast problem. So breast, something which we protect. So we meet elite people. Half the time people come in very late. So the worry we always have is whether breast disease is always a cancer. Today we have with us Dr. Kirti. Dr. Kirti is a breast surgeon who doesn't always believe that cutting out is the answer. So she is one person who thinks when you don't need to cut out, don't cut it out. So with that introduction, I'll let Kirti start it off.
Yeah. So hi everybody, and as Dr. Vijayalakshmi said, we are here today to talk about non-cancerous diseases of the breast. So the first thing to remember is that not all lumps, not all swellings in the breast are cancers. So we have various things that you see in the breast that are non-cancerous. They also need to be assessed, checked, and followed up. So don't let them be just because you see a lump, you think it's innocent, doesn't mean that you don't get it checked. It still needs to be checked.
Kirti, now tell me, when do they approach you? For example, not all of us palpate our breast.
No.
So do we need to palpate all the time?
Yes. So I think the most important thing is the self-breast examination. So this is one thing that we keep barking about. It's a very simple tool. You can do it at home. You can do it in the shower, no added cost. And once you learn the right way to do it, you're the best judge of your own breast. So what I normally tell people in the clinic is the way you look at your face every day and when you wash your face, if there's a small pimple, you notice there's a small pimple. So the same way, the more you start inspecting your breast, the more you start examining your breast, you know what is normal. And anything that is abnormal or new from what you normally see needs to be assessed.
Do we need to do it on a daily basis?
No. So doing it on a daily basis is not recommended. What we recommend is do it once a month. So ideal time is for those who are menstruating. So premenopausal women, the week that they finish their period is the best time to check. The breast is less heavy, it's not painful, and you can appreciate changes at that time. Postmenopausal women, at any point of the month, they can keep aside a day and continue examining once a month. I think there are enough studies showing that by doing a self-breast examination, half the diagnosis is done.
You know what, being a doctor itself, I myself have a question. For example, sometimes in the month, especially during menstruation, I find my breast painful and tender.
Yeah.
I mean, is that something to worry about, or is that something women have all the time?
So pain around menstrual cycles is very normal. Sometimes you'll have it in one breast, sometimes you'll have it in both breasts. Sometimes premenstrual you can also have swelling of the breast. The breast may feel engorged, your veins may look a little bit bigger. And some women who have fatty areas in the armpit. So some people also get accessory breast tissue in the armpits, particularly when they go through pregnancy. And that can also be painful and tender when you have your menstrual cycles. That is very normal. We don't treat it. We don't advise treatment for it. The only thing you need to do is wear a good supportive bra and some topical analgesic if you have pain. Nothing else
bringing
works.
about the bra. So we'll finish off this. So one thing madam has said is, if you have a swelling in the armpit along with the pain in the breast, don't panic. It may be normal, but then doctor has to confirm that.
Yes.
Now coming to the bra question.
Yeah.
This is a perennial question.
Yeah.
Does bra really have a protective or detrimental role with regards to cancers and stuff?
So I think there's a lot of myths going around that if you wear a black bra, if you wear an underwire bra, you can be more prone to getting cancer, and that is all wrong. You can wear any kind of bra. The main important thing of wearing a bra is to give you good support. So this is the thing, people come in with a lot of pain, even non-cyclical pain, so pain that doesn't come around your menstrual cycles. And the thing we say is if you hold a 30 kg bag in your hand without support underneath, you'll have pain in your shoulder. So the same way, if you don't support your breast with a bra, you will have chest pain, you will have pain in that area. So that is why we stress on wearing a bra, be it underwire, be it black, be it anything, it does not matter.
And make sure it supports you well and it's not painful.
Exactly.
That's something we forget because we women always adjust. If it's going to be a bit tight, it's okay, adjust. Exactly. If it's difficult, adjust. No, you don't need to adjust.
It has to be proper fitted. Yeah.
Now, after coming about this condition, now tell me if somebody has a lump. Let's say I self-examine myself and I find a lump. Let's say fairly a half a finger sized lump.
Yeah.
What do I do next?
So when you notice,
not a simple answer. Say, come and see me. We want a longer.
You want a longer answer. Well, the simplest thing is go see a specialist. But when you find a lump in the breast or a swelling also, so sometimes people may not appreciate a lump. They may just notice a swelling on the skin in one part. So whichever part of the breast or the armpit you notice a lump or a swelling, The first thing is to have it checked by any healthcare worker. So even a trained nurse practitioner is fine. One is to get it checked by them. And secondly, do an imaging. So what we feel by hand may not always be what is inside the breast. The best way to know what is happening inside is to at least minimally do an ultrasound scan. So in young women below the age of 40, we do not advise mammograms. We do not like women under the age of 40 doing mammograms. The breast is dense, you don't really see much.
Oh,
What
okay,
we
okay.
advise is an ultrasound of the breast, which is a simpler tool for screening.
And less painful.
It's less painful, and if your lump is of an infection, it is better than doing a mammogram in the breast. So again, when there is an infection in the breast, we don't like to do mammograms unless we see hard lumps or hard areas which we want to define better.
Let's say if there is some family history of malignancy and stuff, do we start the screening early then?
Yes. So if there is a family history of cancer, a strong family history of cancer, so more than one or two primary members with breast cancer.
That's huge number.
Yeah. So it is a huge number. So if you have that many people with a family history of cancer, we ideally say start screening from the age of 25 to 30 years. You need to start early. Now, because we can't do a mammogram in this age group, we either prefer an MRI of the breast once in 2 years ideally, because that defines the breast a bit more in this age group. It defines the dense breast a bit more. And there's a new technique called a tomomammogram. So a tomomammogram does a 3D synthesis of the breast, which is as good as an MRI. So if you have a tomomammogram, you can do that below the age of 40, otherwise an MRI of the breast. A regular mammogram below the age of 40, we do not recommend.
Now, when I have a swelling in the breast, what is my chance of having a cancer? Because immediately I get a heartbeat going up, I panic, and obviously I may not be able to meet the doctor immediately. So, and I don't want patients also to say, this looks okay, I can stay at home and meet them after 2 months.
Yeah.
So, how do we go about it?
So, when you notice a lump in the breast, about maybe only 20% of the people that we see with lumps in the breast are cancers. The remaining 80% are all non-cancerous lumps, non-cancerous lesions. So even whether a cancer or benign, so the same thing I say, if it's a cyst, if it is an infection, if it is a fibroadenoma that's causing the lump, you still need to know what it is. You still need to know what is my follow-up, what is my treatment, do I need surgery or not. So it's not only for cancers that you need early detection, it's even for non-cancerous lesions. Especially infections, because the longer you leave an infection, the more likely you'll end up with surgery. The quicker you pick up an infection and treat it, you're getting away with just antibiotics or additional medication. So it's important to always get an imaging done, one. Two, we do something called a triple assessment. So a triple assessment is a tissue biopsy. So again, when we say tissue biopsy, people get scared thinking that this means cancer. And that is again another myth. We do not do biopsies only for cancers. We do biopsies even for benign breast diseases. So it's like doing a blood test. If you want to know if you have diabetes, you get a blood test done, you know you have diabetes. The same way, if there's a lump in the breast, you want to know what this lump is, you need to do a needle test.
In other words, unless you take a biopsy, we may not be able to say 100% what it is.
Exactly.
So it is only a differential till none. Only when you have a biopsy, we know it is a benign thing, it is a cancer, or it is an infection. So biopsy is just a test, and even children undergo it. It is not very difficult. It is easily accessible, not very costly. Simplest way to assess and figure out what is the problem.
Yeah, exactly. And it's done in the outpatient basis. So you can go back to doing your routine work once the procedure is done.
That means on the same day.
Yeah, it's done in the outpatient department.
As simple as that. It's like you come, you get it done, and you go back to
home.
work.
That's why I said it's like a blood test. You come, you have the test, you go back home. You'll have a band-aid at the area of where the needle has been put in, just as you have when you have a blood test. For some women, they feel a bit of pain naturally. So if you bang your hand somewhere, you will have a little bit of bruising, a little bit of pain, and that's what you feel after a biopsy. So it's a very simple tool, but it gives us a lot of answers. It tells us how to go about what we're doing next. So a triple assessment is absolutely required for all lumps and swellings in the breast.
Can you tell me what this triple assessment is?
So the first part, there are three things involved. One is examination by a healthcare worker, which we had already said. That's the first step. You go to the hospital, the healthcare professional examines you. If they feel like everything is normal, it's just, so everybody's breast is different. Some breasts are fatty, some breasts are very lumpy. And sometimes people think a lumpy breast has a lump in it, which is not true. So if your breast is normal on examination by a healthcare professional, you may not even require anything more. Only when we suspect something there, then you go for imaging. So that's the second part of the triple assessment. So imaging will either be a mammogram or an ultrasound depending on your age. And finally, the biopsy, which is the third thing. So this is the gold standard for diagnosing any breast disease. All three are done in the outpatient setting. You don't need to be admitted in the hospital for it.
We're talking about non-cancerous benign lumps.
Yeah.
What do you mean by that?
So the breast has ducts that go behind the nipple, you have glands, and then you have fatty tissue. So any change in any part of these three structures can cause lumps. So we'll start with the ducts first. So the ducts that go behind the nipple, they produce a bit of fluid. This gets absorbed into the breast tissue in normal physiology. Now sometimes the ducts become a bit loose, they don't have good function. The fluid ends up staying there static and that collects into a pocket. So it's like a little balloon. The more fluid that keeps filling in, the bigger it becomes, and then that feels like a lump. So this is something that we call a breast cyst. Now this is a very common lump that we see in the clinic, more common than cancers, more common than infections, and more common than fibroadenomas. So a breast cyst is just a part of normal change. You don't need surgery for it, you don't need treatment, but you need to follow it up. So sometimes they can get bigger, they can cause disfigurement, they can get infected, and at that time we may need to put a little needle in, drain out the fluid, and that is the treatment for it. Maybe antibiotics if you're infected.
Now this you'll be able to pick up with a scan itself, or you need to take a biopsy?
No, we don't do a biopsy for a cyst. We do only a drainage of the cyst if it's large. Again, if it is small, if it's not causing pain, just leave it alone, keep it on follow-up. You don't need to do anything.
And can it become cancer?
So simple cysts don't become cancers. You can have cancers growing within the cyst just as within the rest of the breast. So because you have a cyst, it doesn't mean this will become a cancer. It does not increase the risk for cancer. But just as the rest of the breast, you can have a growth within that as well. So you need to screen routinely.
In other words, don't cut your breast out because you have a cyst.
Exactly.
As simple as that. So
Yeah.
it's a cyst, you follow up, that's it. So people like Dr. Kirti will follow up and tell you whether you need something. No need to cut out just for a cyst.
Yes. So the second most common thing we see are fibroadenomas. I think if you screen 100 people in the population, 80 people will definitely have a small fatty lump in the breast. As I said earlier, we have fatty tissue and glands within the breast. And just as you have fatty lumps in your hand, on your back, on your thigh, you can get them even in the breast. Again, these are innocent just as they are anywhere else in the body, and you don't need to treat them. So keep it on follow-up. The only time we suggest surgery for these sort of fatty lumps, again, is if some of them have a tendency to grow bigger, just as the ones that can grow bigger on your hand or on your thigh, they can compress on a nerve, cause a bit of pain, then we go in and remove it. It's the same thing in the breast. If it's large, causing you pain, then yes, we take it out, otherwise leave it alone. It stays with you till you die, it does not cause any trouble.
Does it become bigger and bigger?
Some of them become bigger, some of them shrink and become calcified.
Okay. Wow. Okay.
So when they become calcified, again, we don't need to worry about any changes, nothing happens. The ones that get bigger, you want to remove it because sometimes when they start growing, they can grow to an extent where it disfigures the breast. And when you want to remove it at the time where it's large, you're removing more breast volume, more disfigurement in the breast, and more asymmetry between the breast that you don't operate on. So the earlier you pick up that this is a growing fibroadenoma and you remove it, it's a simpler procedure, less disfigurement in the breast, less volume loss. So that's how we look at it.
Fine. So is there anything else apart from these two for benign things?
So these are the two most common benign things that we see. And then of course nipple discharge. Nipple discharge is a problem that you see in all age groups. They come in premenopausal women, they come with people who have stress and anxiety issues, you see it in pregnancy, you see it postmenopausal. So nipple discharge is something that you see in all age groups. And again, nipple discharge does not mean there's a cancer sitting behind. When it is bloodstained, yes, we need to look at it more carefully. But if it is clear, if it is milky, if it is greenish, we just leave it alone. It could be due to hormonal variations. It could be due to some antacids. So a lot of people have a habit of taking pantoprazole, omeprazole, Rantac, and they take it over years because of gastritis.
Yes.
And these are the common medications.
They take it like water every
Exactly.
day, like brushing your teeth, it goes in.
Goes in. And these are medications that commonly cause nipple discharge. So cut down on that if you're troubled with nipple discharge is what I would say.
Next, coming on to the infections.
Yeah.
How often do you see infection in the breast tissue?
So we do see infections within the breast. So when you look at infections in the breast, you look at infections on the surface of the breast and infections within the breast. So the skin over the breast tissue has sweat glands and it has hair follicles. Sometimes this can get blocked and it forms something called a sebaceous cyst which can get infected. Now, if it is an infection like that, we just need to do some antibiotics. Sometimes you need a bit of drainage to remove the pus. You don't need to do anything further. It's just as a pimple on your face. So if you get a pimple on your face due to blocked glands, you can get it even on the skin over the breast. We don't see that very often, but we do see maybe about 20 to 30% of people coming in with that. Similar to the armpit, a lot of them get it in the armpit more than in the breast. But the infections that we worry about more, and then we come to you for help.
I also add a condition called hydronitis. So
Yeah.
under the breast and axilla, we often see this people in the young reproductive age group
Exactly.
they have proliferation of these glands. So they have this kind of a pus discharge, swelling, disfigurement.
Pain.
So especially it's very common in our country and we see it under the breast and axilla. Again, it has got several management. One part is medical, medicines, lifestyle, weight reduction. If it doesn't work out, you remove the skin and graft it. So it's multi-pronged. And again, that's again a benign condition, but there is quite a bit of disfigurement and foul smelling ooze. May
That
not be
comes
very
with it,
painful.
yeah.
That's something which we see very common in the skin soft tissue area. Then
And I
going
think
deep into the
the other thing about hydronitis is shaving. So the more you shave, the more
more
prone
it
you
comes.
are. So avoid that if you're prone to having swellings in the armpit. Right. Now coming to the more difficult infections that we deal with, that we usually send to you. So just as you can get infections anywhere in the body, you can get them in the breast. And the deeper infections, I think you'll be a better judge of how we divide them into what different types of infections we see and how we treat them.
So we talk about infections of the breast. We have divided into two categories. One is patients having infections during an acute phase, for example, during your pregnancy, postpartum, post-trauma. So any kind of injury to the breast. So postpartum, when you're feeding the baby obviously is going to clutch on. There's quite a bit of contact. There is inoculation. So that's when they come with a bacterial infection. Post-trauma, during lactation, or any kind of during pregnancy. It's most likely when you're lactating and when post trauma, that's the commonest time when you come with a bacterial infection of the breast.
Yeah.
Commonly caused by an organism called the Staph aureus.
Yeah.
Here you will require drainage, which is usually an aspiration. They put in a needle, aspirate the pus out, and we start antibiotics to settle down. Generally, we advise breastfeeding in the same breast too.
Yes.
Because you can tell why we
So
say.
when a woman is breastfeeding, the most common cause of getting an infection is two things. One is either the milk duct is blocked and there's milk collecting inside, bacterial growth growing within it, or through the baby's mouth because your nipple has openings. Children carry bacteria in their mouth, and because of contact, you can then start developing an infection. The important thing here is to continue feeding. So if you don't feed at that given point of time, there's more milk collection within that breast. It becomes more engorged, you're worsening the infection. I think the common myth is that if I feed, I'm going to pass on the infection to the child. And that is actually wrong. So when the infection goes into breast milk, it becomes inactivated. So you can't transfer the infection to the child, but you're still breastfeeding your child, so you're still giving your child good immunity. So when you have an infection in the breast, particularly during pregnancy, the best way to deal with it is hot packs, massage, and then express. So if you're worried to feed your baby directly or you're finding it painful, use expression by Palade or a breast pump, and then you can still feed the milk back to the child. Don't ever stop breastfeeding on that same breast.
So the issue to take over now is breastfeeding if there is an infection, because if you don't feed, the milk is going to stagnate, it's again going to get infected. What could have just gone away with an aspiration will end up with an open surgery, and you will not even feed your baby. In other hands, express the milk. If you can't, come out to the hospital, our lactation nurses will help you out, our consultants will see, and then keep feeding the baby. As the baby feeds, whatever other milk products, the active ones, non-infected ones will still feed the baby. They won't be a block and we can remove this off. So it's a simple problem, don't make it complicated. because every week I end up seeing 1 or 2 cases of patients have stopped feeding just because they had an infection in the breast, which is because almost every woman postpartum, including all of us, have some kind of a time where you had some breast engorgement. That's pretty common in the first
breast
pregnancy.
engorgement is very common in the first pregnancy, particularly. I think
I would
where
say in the city, there's not been one person who didn't have it. True, no?
that is true. That is very true, and I think it's because of latching issues that people have initially. So you see all these infections in the initial postpartum period where people are struggling with latching.
2 to 4 weeks, almost everybody has some engorgement.
Engorgement. So that is very natural. But don't stop feeding. Don't give up on it. You need to massage. You need to give hot showers. Only then the ducts and the glands open up, and then this flow is better. Continue feeding because that also opens out everything.
Next comes these uncommon infections, because certain infections were endemic in our country, like for example TB.
Yes, exactly.
So very rarely we get TB of the breast, but then remember, primary TB of breast tissue is very, very, very rare. I'm a TB specialist. I'm managing TB patients for 20 years, probably seeing the maximum number of cases. I would have had 2 or 3 patients. Well, I'll be seeing at least around 200 TB cases in a month. And imagine if such a number, if I could see 2 or 3, that's pretty uncommon. Primary TB in the breast is very uncommon. Similarly, we have a condition called brucellosis. It presents with abscesses in multiple areas. Again, primary abscess in the breast without any other areas also very uncommon. These are two things which can present with a chronic abscess in the breast. Occasionally, conditions like melioidosis, some other bacterial infection which is having septicemia everywhere can lodge. Again, all these 4 conditions are very, very rare in breast. But we do see one other conditions where women come with florid pus production in the breast. Kiti, will you initiate it?
Yeah, so we see a lot of women coming with not just florid pus pouring from the breast. So we see a lot of people coming with lumps which don't look like cancers, don't look like innocent lumps. They've got a lot of fluid within it. You see areas of thickening within the breast. You see discharge coming out from the skin in the breast, not just the nipple, but from areas where this infection has inoculated. And sometimes even with swellings in the armpit, because when you have an infection, your lymph glands automatically swell. And when you have a lymph gland in the armpit with a lump in the breast, the common thing that people think is this is a cancer. But even infections can present with hard lumps, they can present with lumps in the axilla, and that is how these idiopathic infections come within the breast. So here again, I know I said we don't like mammograms when there's an acute infection in the breast. But because these are chronic infections in the breast, the way to diagnose them is to first do a mammogram and an ultrasound over 40. Below 40, again, just an ultrasound. Now, because they're chronic infections, a lot of them will not have pus as such to take out for cultures, but we can still take out the tissue via a biopsy, similar to the triple assessment, and then send it for testing to see what is the bacteria that is growing, is there tuberculosis or not, is there any other type of infection or changes or inflammation that we see within. So as far as our play in this goes is diagnosing the patient and making sure that this is what it is, and then we send them to you. So how do you treat them now?
So basically, this is a condition of exclusion. When I say idiopathic, it means that the cause is unclear. So the hypothesis is body's immune cells. We have cells called neutrophils and lymphocytes. These immune cells fight against infection. So in some women, these immune cells assume a part of the breast to be an infection and starts fighting against it. So they become a swelling, and then the swelling slowly, the part of the swelling dies off. It necroses, it becomes pus, makes small holes in the breast surface, and it comes out. So most of the time when they come, they'll come either as an isolated lump or a lump with some focal pain, very severe pain in that area. If you palpate that area, it will be a palpable swelling which has got inundation, or they will come with multiple sinuses. Sinuses are small holes in the breast surface where pus will be oozing out. As I put these 3 scenarios, these are the stages. Initially a lump, then the lump, small areas necrose off in the lump, and then the areas when the pressure builds up, it opens out in the surface.
Sinus, yeah.
So 3 ways they come in. When we take a biopsy gives us an answer, because biopsy shows something called granulomas. These granulomas we generally see in TB and brucellosis. So we do some tests to exclude those things. And if with an exclusion and histopathology, we make a diagnosis of a condition called as idiopathic granulomatous mastitis. Kriti, do you ever cut out in IgM?
No. So the main thing to remember here is in an idiopathic granulomatous mastitis or tuberculosis of the breast or brucellosis of the breast, all chronic infections, have two phases. One phase where the chronic infection becomes acute, they have acute symptoms of pain, redness, swelling, discharge. And then with medications, it settles down, it goes into a chronic phase, and sometimes they recur. And in both phases, you don't want to operate because when you do a surgery in an infected breast, which has an active bacteria or growth happening at the same time, when you do an incision biopsy, so sometimes people say, let's remove that bit of tissue and see what is in it. They don't heal well. They form a fistula, which is a tract from where you've taken out the breast tissue to the skin. And as you said, even sinuses. So it becomes a chronic problem where healing is an issue. So we do not like to operate in the acute phase. Now for normal infections that we were talking about, like bacterial infections that can be recurrent, apart from in pregnant women, say even diabetics. Diabetics are very prone for infections in the breast as well. You can do something called a total duct excision where you disconnect the ducts from the nipple,
Okay.
which prevents further recurrent infections. But it is not advisable in IgM because in IgM the issue is not because of the ducts, it's from the breast tissue.
IgM is not an infection, as I said, it's idiopathic. So if it's going to be a recurrent ductal infection, which somehow it's not that very common here.
It's not very common here, no. So ductal infections, you see them very commonly in diabetics, as I mentioned. So people with uncontrolled diabetics, once they have a ductal mastitis, like infection in the duct, they can have
having recurrence.
So in those patients, yes, you can disconnect the duct. And in smokers, so in smokers you see it very, very commonly, and even in males. So you see a lot of male people also having nipple problems, infection around the nipple, and this is common in both genders. So in that case as well, you can disconnect the ducts. But in the types of infections that we have just covered, in tuberculosis, in brucellosis, in idiopathic granulomatous mastitis, it's all not occurring from the duct, so there is no role for surgery. It is only medical treatment.
So if it's going to be TB, we give it ATT. If it's brucella, we give them treatment for brucellosis. If it's something called idiopathic granulomatous mastitis, again we categorize them. So depending upon the category, we may just follow up. Some group of patients, when we feel the disease is going to end on its own, we just have to wait. The patient does not have pain, it is not progressing very fast, we just follow up. Again, one thing we all have to remember is treatment is not just giving medicines. Treatment is also following up when to say not to give medicines. So sometimes we don't give anything. And sometimes certain patients we follow up with giving a lot of medicine. Some of them will have something called as immunosuppressive therapy. So basically we are kind of playing a hoodwink game with the immune cells in our body. So we suppress the immunity and slowly bring it out. So body takes over without considering the breast as a pathogen or an alien. So slowly we suppress the immunity briefly and then bring it out. The basic concept is this is an aberrant condition. That is, by mistake, the body is thinking that there is a problem in the breast.
Yeah.
Once we kind of stop that particular memory cells because it should come back to normal. That's basically the assumption. So majority of them settle down. A small proportion can keep on progressing, where we may have to go from first line to second line, sometimes repeated aspiration, and some people will require more treatment. There is a group who just simply settle down without anything. So it's actually one full, from one end you'll have patients completely stable, other end patients will keep coming back, recurrent aspirations, prolonged therapy. It varies. On an average, by 1.5 to 2 years, majority of patients settle down.
Yeah, within 2 years, actually, most of the patients settle down. But it's like you said, it can be a wide range. There are people who settle down within weeks, and then you have people who have an ongoing problem for 2 years. But even with ongoing problems, we'll still stress that there is no role for surgery here. I think you will
there
agree,
is no
it's
need
only
because
medical
its point
treatment.
is it's just medical treatment. Majority of the time, the problem comes in when we have multiple scarring tissue comes in, it becomes disfiguring. So when we pick it up early and we have a lump which is growing bigger, if we initiate treatment at that particular time, it becomes much more easier. So you don't get unsightly scars over the breast tissue. You don't require to go for repeated aspiration. If it's going to be a small lump, again we are not going to treat. We're just going to follow you up. So that decision is where you're coming back to us becomes important. Similarly, once we start on immunosuppressive therapy, the follow-up has to be prompt because these are drugs which can be as useful as possible. They can be detrimental too. So we need to be very careful when we give it. And the duration also can be anywhere between 6 weeks to 6 months, depending upon how the body progresses.
And I think it's important, particularly when you're on steroids, that you continue the treatment, taper it off the right way, and don't abruptly stop, because then your recurrence is higher.
Another thing is, when they stop your steroids immediately, because this is basically, as I said, it's a game with the breast, with the body. So if you stop in between for 2-3 days, the dose doesn't work. Because you start at a dose, you slowly taper it off.
That's
stopping in between. So the biggest problem we face is they'll decide the doctor's not there, doctor's on leave, or I have to go for some temple, I have to go to the church or something like that, and they'll stop it for 3-4 days, 5 days, and then they come back. Now what do you do? Because you know whatever you've won, you've lost it.
Exactly.
So that's where the trouble comes. It has to be a continuous follow-up.
There has to be continuous follow-up. So ma'am, now that we're in the time of COVID vaccination, where we're vaccinating routinely and everywhere, any concerns that you've seen within the breast or the armpits after vaccination? Because this is another thing that we've been not a lot.
Within a breast, no. You can have, see, this is an injection on your deltoid. Deltoid is on your upper arm. When you give an injection in the upper arm, this is something which produces immunity, and you have immune cells in your armpit. So some of these that's called lymph glands. So lymph glands can become bigger for some of them. Some of them we can have a local necrosis. The area can become swollen. At that time you can have glands going up, and you may have pain. There is one, the lymph glands in the axilla have 4-5 areas. One of it is on the lateral side next to the chest wall, which will be very close to the breast. So that pain will almost look like a breast pain.
Yeah.
There are quite a few patients coming back and saying that I have pain in the breast, but it will be on the same hand where you had the vaccine, and that's actually the lateral group of nodes.
Yes. So
that's
you are
seeing, tender.
Yeah. Yes. So we are seeing a lot of people like that. So post-vaccination, getting swollen lymph glands is very common. It's not a reason to not vaccinate.
And you just take paracetamol 2-3 days, it will settle down.
And it will settle down. Just like how you may have a little bit of body ache after the vaccination, a little bit of mild fever after the vaccination, you can also have swollen lymph glands, pain in that side of the breast. It's not a reason to not vaccinate. It is normal.
And it's kind of indicates that your body is reacting. So obviously it may even turn out to be better. Yes. Who knows, your immune response may be even better.
Much better, so you can develop better antibodies.
We don't know, it is just supportive talk. So your reaction doesn't mean it is bad.
And you don't need to treat this type of mastitis or this type of swollen lymph glands. I think you just leave it be for 2-3 days, take your paracetamol or Dolo, and it should settle down with that.
If you have a doubt, meet the doctor. So they'll be able to differentiate between something in the breast and in the lymph node. That makes it a healthcare provider, RPting will be able to tell you.
Yes. Yeah. So any other questions, ma'am?
So, and we'll finally finishes off with the autoimmune disorders. There are a group of patients coming with SLEs and other things.
Yes.
Some of them come with pain in the chest wall. Some of them say breast pain. Majority of them have this chest wall pain is pretty common in patients with all these autoimmune disorders. So do we need to screen them with a mammogram or ultrasound, or how do we go about it?
So again, the screening protocol for any breast diseases works the same. 40 and above, mammogram and an ultrasound. Below that, ultrasound first. So when we have seen some patients with autoimmune disease presenting with lumps in the breast or just pain as well. Now, most of the time, because the pain is in the chest wall, all the nerves that supply the breast come through the chest wall into the breast. So any inflammation within the underlying structures, like the muscles that support the breast or the ribs underneath the breast, can also cause this sort of pain. But when it comes to particular autoimmune diseases, such as, we see a lot of people with plasma cell mastitis, and you do an IG panel, it may pick up some sort of autoimmune disorder within that. So these sort of people also benefit from a biopsy. Sometimes if it's a localized nodule, so you see some people will come with one particular nodule in the breast, which will not be cancer. A core biopsy may not give you an answer.
Sorry.
Oh, bless you. We just remove the whole nodule and send it away for testing, and then they can do staining on that to see if this is also part of the autoimmune disease or not. So we do see that.
So basically, a biopsy is required.
If a biopsy is required.
Now that brings me to one more question. Yeah. I had a patient who comes and keeps on saying that they have done 2 or 3 biopsies. We don't have an answer. When your biopsy is not Like for example, most of them it's going to be an FNAC or a true cut biopsy. What do you do next?
So, FNACs of the breast we don't like.
Don't like. Yes,
We don't like.
FNAC is not something which is Kirti's favorite, not any breast surgeon's favorite.
No. So
or to add us at the ID team also. FNAC is something we are not comfortable with.
No. So, and doing an FNAC and doing a biopsy, you're still putting a needle in. With a biopsy, you're just putting a bigger needle in, you get better answers. So, we do not like FNACs in the breast. Sometimes when you do a biopsy, you can get inconclusive results. Microscopy is very important. So what kind of plasmacytic infiltration or lymphocytic infiltration, they will mention something there. So that will give you a bit of guidance as to what could this possibly be. If you don't get an answer with repeated core biopsies, first thing is to make sure that the biopsy is being done image guided. So the tendency is that if you have a big lump in the breast, you can feel the lump, why can't you put a needle in directly? And where we go wrong is that if you have a large lump particularly, or any lump, the central area may not have tissue that is representative. The central area might just have fluid or necrosis. So when you do an ultrasound guided biopsy, you know exactly where the needle is going. So you take out tissue that is representative. So that's the first thing to check, is if they've had an image guided biopsy, because that's very important. Now, even with image guided biopsies, if you get inconclusive results, if it is a localized lesion, you can remove it provided there is no acute infection. So when you remove that whole localized lesion and send it for testing, you'll have a better answer of what it is. There is a staining set of panels that they do, just as you do your ANA, your RF factor, to look at systemic autoimmune diseases. You can do staining to look at IgG, IgM within the tissue itself to see if there's any autoimmune disorder happening there.
So the point is, the routine just getting an FNAC for a cyst or a fibroadenoma actually doesn't mean anything. So we don't come to a conclusion based upon it. So probably her hands or maybe a true cut biopsy will give us an answer more than an FNAC.
Yes.
So I think we'll with that. So the final point being, no FNACs routinely. If you have a swelling, meet a doctor. And if there's going to not all swellings needs to be cut out. So follow up is very, very, very important. Kirti, your last words, closing remarks.
Self-breast examination. So I'll come back to that. I think the best way to diagnose any breast disease is to do a self-breast examination, because if you don't find it and come to us, we're not going to find any disease there. So you need to do a routine self-breast examination once a month. That I think I would remember that, and remember that not all lumps are cancers, but they all still need to be evaluated.
Thank you.
Thank you.